Okay, there we go. And so yeah, so today I have the pleasure of introducing Dr. Stephen Lopez. So Dr. Lopez is a professor of psychology and social work at the University of Southern California, where he also serves as the director of clinical training for USC's clinical psychology program. After completing an undergraduate degree at Claremont McKenna College, Dr. Lopez was a mental health worker at La Frontera Community Mental Health Center in Tucson, Arizona. 2 years later, he entered the clinical psychology program at UCLA, in which he furthered his interest in improving mental health services among Latino communities. Prior to joining the faculty at USC, Dr. Lopez was a professor at UCLA. His program of research lies at the intersection of culture, serious mental illness such as schizophrenia, families, and intervention, work that has been continuously funded by the NIH and many other organizations. Dr. Lopez has received numerous awards for his research, mentorship, and teaching, including the Evis Coda Award for Building Hope for families due to his longtime leadership in the pursuit of cultural competency in mental health service provision, specifically to Latinos. Today, he'll be presenting some of his incredibly important work on decreasing the duration of untreated psychosis among Latinos in the United States. And we're super happy to have him here, so please join me in giving a warm welcome to Dr. Lopez.
Thank you very much, Will, and thank you all for inviting me. I'm happy to share our work with all of you. As you know, given that Ty and Mary are at Yale, this is an exciting time for the study of psychosis, both in terms of the study and also in terms of the treatment. And this whole initiative to intervene early so that we can prevent the chronic illness that typically is associated with schizophrenia and other psychotic disorders. We don't have to have that chronic notion of schizophrenia. People can lead full lives, particularly if we intervene early. So it's an exciting time, but what I want to do today is I want to critically examine that initiative to support early psychosis treatment. And I want to do that through the discussion about bringing treatment to underserved communities, in particular Latinx community, and also low middle income countries like Mexico. And my main goal here is to point out the importance of reaching out to underserved communities. So here's an example of some of the increasing attention to early psychosis interventions. Coordinated specialty care is developing across the nation, almost like wildfire. SAMHSA gives block grants to states so that they provide early intervention. NIMH has this new EpiNet, well, not so new, but they've had 2 now calls for research proposals. And they draw on the Institute of Medicine's concept of learning healthcare system, which is really an opportunity to bring healthcare systems together, collect data that's using similar measures, and then using that data to inform care, to improve care, and as well understand the condition. And so NIMH is very much supportive of these regional networks of services, and Vinod Srihari and John Kane are one of the leaders of one of the EpiNet groups there in your area. So why is early intervention important? Probably don't have to spend much time on this, but this concept of duration of untreated psychosis is real central to our talk. But so looking at early intervention, looking at early psychosis, those folks with first episode psychosis with longer durations of untreated psychosis. So duration of untreated psychosis is the time period from the onset of the illness to when they first get care. Now there are multiple ways you can have the offset of care. Do they first get into any kind of health care? Do they get into mental health care? Do they adhere to antipsychotic medication or receive antipsychotic medication? Do they adhere to antipsychotic? I think we really need to use multiple measures of the duration of untreated psychosis. But the main point is the longer the duration of untreated psychosis, the worse clinical and social functioning. And so Norway, I know Mary, you've been, I know Jan Olav Johannesson and Inga Joa, actually they invited me for their 25th celebration, 25th year celebration of their TIP study. And I know that you've trained them with their multifamily interventions. But the TIP study, the folks in Norway really have led the way. And they were the first group to actually reduce the duration of untreated psychosis. This was a paper 16 years ago in the Archives of General Psychiatry. Just let me spend a little bit of time on this. They did a quasi-experimental design where they had an early assessment team in 3 locations, Rogaland County, Norway, someplace in Denmark, I think, Copenhagen, and also in Oslo. So they had 3 sites, and they each of these sites had this early assessment and treatment team, kind of like a coordinated specialty care, the precursor to coordinated specialty care. But what was different in Rogaland County is that they had a widespread campaign where they were in the newspapers, where they had, where they're at schools, they were with healthcare professionals, they were working with the criminal justice. So they had the widespread campaign. And what they found is in the control conditions of Oslo and also Denmark, the duration of untreated psychosis was 16 weeks, but in Rogaland County, it was 5 weeks. Can you imagine a duration of untreated psychosis? 5 weeks. That's incredible, because if you're looking at the RAISE study, the median is 74 weeks, so over a year. And in general, it's 1 to 2 years. But Norway has a lot of money, and it's a small country, and there's a lot of advantages to their systems of care. And the other thing that's really important is that this reduction in duration of untreated psychosis, you could assess that, you could see the effects 10 years later. For example, suicide rate was lower in Rogaland County. So they've been able to lead the way. Another key study is the RAISE study. Here's John Kane and his group published the RAISE study where folks were assigned to the Navigate, which is a coordinated specialty care, and they had their treatment as usual. So the orange figure here is the Navigate, the coordinated specialty care, and here is treatment as usual in communities. Yeah, and so what you see here is this is a quality of life, and here the PANS total score. So the symptomatology, we're going to just focus on the quality of life. And you can see, and they looked at duration of untreated psychosis. So they did a median split, and those who had less than 74 weeks of duration of untreated psychosis had an increasing quality of care. Those with greater than 74 weeks had increasing quality care, but not the same extent. And then here you had no difference in terms of duration of untreated psychosis with regard to the community care. So John Kane and his colleagues concluded that prolonged duration of untreated psychosis is an issue of national importance. Reducing duration of untreated psychosis from current levels from greater than a year to the recommended standard of 3 months should be a major focus of applied research efforts. So the idea is not only is duration of untreated psychosis related to symptomatology and social functioning, but it's also related to treatment. And if we can reduce the duration of untreated psychosis and get people into care soon, they can benefit from treatment. So here's some of the aspects of coordinated specialty care. Nick Brightborn, Mary and Ty know Nick, now at Ohio State University, is a student of mine. He tells me that these kinds of services vary from state to state and region to region, but these are some of the services. I see it as kind of throwing a lot of services at folks, but clearly it's working. It's working. There's some limitations though. One limitation is that it's really hard to reduce the duration of untreated psychosis. In a meta-analysis in 2018, Oliver looked at 16 controlled studies, and they found that the effect size was close to zero. In fact, I can only count on 4 groups that have demonstrated a reduction in duration of untreated psychosis. If you think about it, it's a really complex construct, and there are multiple intervening variables. And so there's a lot going on, and it's really hard to reduce. Another limitation is that there are no published DUP reduction programs in lower and middle income countries. They're all in high income countries. In this meta-analysis, Oliver identified all these countries, including the STEP program that Vinod Srihari leads. Alex Capello, it's a colleague of mine, a psychiatrist, says he was born in Argentina, says that Hubei, if that's how you pronounce it, is really a low income area within a high-income country, but there's no published reduction programs in lower and middle-income countries. Another thing too, thinking about the high-income countries, there's so little attention to assessing high-risk groups, in particular communities of color. So we have these outcome studies with racial untreated psychosis, but little attention to communities of color. And one, just in terms of sub-analysis of the communities of color is limited, but also thinking about how these DUP reduction campaigns are carried out. There's little attention to issues of culture. The best study, in my opinion, is Chong and his group in Singapore, carried out a DUP reduction program. And in Singapore, they had these televised docudramas, kind of like a soap opera, in 4 languages, English, Chinese, Malay, and Tamil. But there was no discussion at all about the possible cultural issues and how you communicate what is psychosis and how to bring people into care. And a fourth limitation is that the emphasis on early psychosis, all about the clinical service. The assumption is if you build it, they will come. But the main finding, I think we're getting lost, we're not paying enough attention to this. The main finding of the TIP study is the DUP reduction wasn't associated with the special services. It was the services that was associated with a multifaceted campaign. And if you look at the EpiNet and you look at the block grants, there's a little attention to the community outreach. And particularly for low middle income countries, and particularly for communities of color, simply building the service may be insufficient. And you think about this conceptually. Lode Roigler and Dharma Cortez, I have an important paper in American Journal of Psychiatry, conceptual framework about help-seeking pathways. And they argue, and it's very simple-minded, but it makes a lot of sense. They argue that there's a symptom onset. Well, who's going to determine whether or not that person gets in when the symptom onset? The family, right? They then say there's the social networks. These are important pathways to care. So you're talking about the teachers, you're talking about friends, you're talking about healthcare providers, you're talking about criminal justice system. How well do they facilitate people getting the mental health? And also the mental health system is a pathway to care. In fact, Max Birchwood in a 2013 paper, this really opened my eyes. One of the barriers to treatment is if somebody was referred to a mental health service. A mental health service, how do you explain that? They go into the mental health service and they don't come back. Nobody reaches out to them. They don't follow up with an appointment. The mental health service doesn't follow up with that. And so that's why the coordinated specialty care is really important, because the folks who are providing those cares will reach out, will contact, hey, you didn't come in, may even do a home visit. But getting into the general mental health system can be a barrier to actually getting the services in that one important study by Max Birchwood. So the point is that coordinated specialty care will certainly facilitate getting folks into care and engaging, initiating, and follow through with treatment. But how about understanding the predicament, the families? How about the teachers, the healthcare providers, the criminal justice system, friends outside the family? So you need a campaign to address the family. You need a campaign that addresses the lay and the professional networks. So coordinated specialty care may not be sufficient. So I've spent my life as an academic focusing on the Latinx community, and it's the largest U.S. quote minority group in the country, and especially in California. And Margarita Alegria has done wonderful work. And in the National Epidemiology Study, the NLAS, they show that Latinos, particularly adults of Mexican origin, it used to be that folks thought Latinos, Latinx, tended not to use mental health services. But people of Puerto Rican background, Cuban background, they have an important study, American Journal of Psychiatry as well, that shows that they're using services similar to whites. But it's adults of Mexican origin, it's Spanish-speaking individuals, it's immigrants. Those are the ones who tend not to use mental health services. And the NLAS didn't assess psychosis. They had just a few questions on that, but this is with data with depression, substance use, and anxiety disorders, but tend not to use mental health services. Another thing, So another thing to consider is Latinos have low psychosis literacy. So this paper that we did in psychiatric services, and most assessment of psychosis literacy, Jorm out of Australia is probably the most well-known person who's advocated for this notion of mental health literacy and psychosis literacy. They typically present a paper, a vignette. It's much like a clinical case. And it strikes me more like a clinical case. And then they ask people, what's wrong with John or what's wrong with Jane? And if they say schizophrenia, if they say psychosis, then they have high psychosis literacy. Well, I think it's a little bit more complex than that. So we asked, these are Latino patients or consumers with first episode psychosis and their caregivers. We asked, what is a serious mental illness? And do they mention anything about false beliefs in their own language, in their own words? Do they mention anything about disorganized speech? Do they mention anything about hallucinations? These are patients with first episode psychosis. These are caregivers. And look at, when you ask them what's serious mental illness, less than 30% of the caregivers and the patients identify delusions. Delusions and disorganized speech are not part of people's cognitive schemas about serious mental illness. Hallucinations, on the other hand, are much more prominent. So if a kid is starting to have some unusual thoughts or disorganized speech, family members, folks aren't going to recognize it as well. The other thing is we presented a vignette. I'll share that with you in a bit, video vignette. And we asked, what's up with Olga or what's up with Elsa? And this, like psychosis, it's embedded in an everyday kind of thing. People have not only the symptoms, but they have difficult relationships. They have problems in school. They have problems in their jobs. And so when you present a vignette, folks aren't looking at the symptoms. They're looking at the problems in relationships. They're looking at the problems with jobs. So when you present a vignette with these symptoms, only 30% of the patients identify a symptom, say that's a problem. He's hearing voices, or she's hearing voices. Or the caregivers, that's a problem. Instead, they focus on the social world issues. And very few, less than 10% of the caregivers or the ill relative mention the word schizophrenia or psychosis. Okay, so poor psychosis literacy, not likely to use services. So the focus of our project was to reduce the duration of untreated psychosis in the Latinx community. We did not work with a coordinated specialty care. The program announcement required us to work with a coordinated specialty care. And actually, Dr. Alex Kapelowitz, a colleague, was part of the RAISE study and had 5 clinicians who were trained in the RAISE and the Navigate, and they provided that at the outpatient clinic. But after the RAISE ended, they no longer participate in that service. So we wrote it up, and anyways, the main point is we didn't work with a coordinated specialty care. It was like we did the campaign on our own. So let's zoom in a little bit with the campaigns, since we focused on the campaigns. The assumption is that campaigns increase psychosis literacy. If you look at all the campaigns, that you'll see that. We need to do a campaign to increase psychosis literacy. But if you look carefully, there's little guidance in the literature on how to increase psychosis literacy. And also, there's no evidence provided that the campaign messages actually enhance psychosis literacy. The best study, in my opinion, is out of Max Birchwood's group. I think Helen Lester was her name. They did a very thoughtful approach to teaching healthcare providers about what psychosis was. It was informed by a conceptualization about psychosis literacy, and they did a good job of teaching the healthcare providers. But these campaign messages, people put them together kind of on the fly, but there's no science associated with it. So in putting together our campaign, we drew on this important document, the health literacy. And there's really no clear conceptual framework. They really throw out kind of a kitchen sink about what health literacy is and what you can do about it. So let's see. So we started at 8:40. What's our time? Do we want to end it? Well, 8:40 for me. I'm sorry.
Yeah, so we have until,
That's
or
okay.
yeah, Eastern side, we have until 12:50 total, but we want to leave 10, 15 minutes for questions. So if we,
So if I go to the half hour, that will work.
yep, that should be great.
Yeah. Okay. And I'll try to do it earlier than that.
Sounds good.
Okay. All right. So we drew on the Institute of Medicine's health literacy, conceptions of health literacy. Linda Garro has some excellent anthropological work in Mexico, and Mei Ye has an important study in San Diego where they assess illness attributions of families and parents and its relationship to help seeking. But let me play with you just to make this really concrete. Not play with you, but let me play for you. This is how we assess psychosis literacy, and it makes really clear this conceptual part. So, okay, that's right, I want to unshare this. So you can see I'm teaching, oh, there you go, good. I'm sure there's an index that you can assess the delay of shared screen time. My delay of shared screen time is reduced, but it still has a ways to go, guys. All right, so here we go. I'm going to show you a vignette. This is how we assess psychosis literacy. Do you see a blank screen? No, I haven't shared
Not
it yet.
yet.
I haven't
Yeah.
shared it yet. Okay, here we go. Okay, you should see it now. Do you see it? A blank screen? It says, what's up with Olga? No?
I think it's just popping up now. I think there might be a little bit of lag.
Let me know when you see it. Somebody sent me a thumbs up.
I was just
Okay,
saying,
thanks, Mary.
the whole desktop. So maybe if you can just make the video part a little bit bigger. Yeah, that's
Yeah,
perfect.
no, I'm making it definitely bigger. Here we go. Thank you. I appreciate Dylan. Thank you for inviting me, Dylan.
Thanks for being here. We're thrilled to have you, Steve.
Okay, so what's up with Olga? This 3 minute.
I think we might need to reconfigure sound. I'm not getting any sound right now.
Each other.
Could you hear it? You couldn't hear it, right?
Oh, I can now. I can now.
Okay, I forgot to take out my earbud. Sorry, guys.
So I don't think they'll be visiting us this summer. Hey, guess what? Remember Olga, my neighbor's daughter? Well, she just got divorced from her husband, Ricardo, after 9 years of marriage. Oh, it's such a shame because they're so young. They're only in their 30s. My neighbor was telling me that the divorce has been really difficult for both of them, but especially for her daughter, Olga, of course. She says that they were very much in love and they really cared a lot about each other, but that the problem was that they couldn't have kids. Well, at least that's what they say. ¿Quién sabe? So anyway, Olga moved back in with her parents 3 months ago after they got divorced. And my neighbor was telling me that ever since her daughter started living there, that she's been acting a little strange. She gets sad very easily and starts crying over things that didn't affect her before. And that she doesn't dress up like she used to anymore. And she's so pretty, poor girl. Her mother has to be after her just to get her to change her clothes and brush her hair. I mean, honestly, if I were that pretty, I'd be out looking for somebody else. Anyway, like I was saying, before the divorce, she was always dressed really nice. I'm telling you the things that happen to people when they fall in love. Oh, and the other day, when I was watering the plants, I heard Olguita saying that her parents, especially her father, had never accepted Ricardo. Imagínate. When I asked my neighbor about it, she told me that recently Olguita had started blaming them for her divorce and that she started picking fights with them, that she got this idea in her head that her parents had done witchcraft to separate her from her husband. Can you believe that? Her father has tried to convince her that it's not true, but Olguita won't listen. My neighbor's really upset about Olga. To tell you the truth, I was very worried about her too. The other day I asked her, Olguita, do you still have feelings for Ricardo? And after a moment she said, well, Ricardo's my husband, and the other day he came by the house, and then I heard the dog bark, but it didn't bite me. My father said that he doesn't want to see him around here. Did you know that I like flowers? Can you believe it? She responded by saying all these things that didn't make any sense. And now that she lives with her parents, they say that she talks to her husband, Ricardo, even though he isn't there. ¿Lo puedes creer? Not only does she see Ricardo, she also hears his voice. Her sister told me that Olga still loves Ricardo and that imagining that she speaks with him is her way of having him close. My poor neighbors, it hurts them to see Olguita suffer this way. Well, who wouldn't feel bad, right? The divorce has been really hard for the whole family. Her family thinks that the divorce has affected Olga a lot. All they want is for this to be over soon and for Olguita to be her old self again. My poor girl, no?
Okay. So what we like about this is that it's a narrative. It's as though somebody's talking to you, and it's an everyday kind of narrative. It's a chismosa neighbor, which means a gossipy neighbor. And it's a little over the top, but anyways, so we ask people, okay, let me go back to my screen. Stop share screen. So we, instead of presenting a case and asking, does John, what's wrong with John or Jane, that has some elements of the social world, we wanted to embed it in the social world, and then do people pick up? So the idea of this simple conceptual model is, if you have some health knowledge, you're more likely to make an illness attribution. You're more likely then to seek professional care. On the other hand, if you don't have much health knowledge, you're more likely to attribute issues to the social world and less likely to seek care. And so that's guided us in terms of our campaign, having a conceptual model. Let me make this screen bigger for you all. And then the other thing we've done is that we want to use everyday language. You know, a lot of campaigns talk about schizophrenia and talk about psychosis and use the technical and the clinical language. We want to use everyday language. So we came up with a mnemonic device. And actually, I went to my wife, Mary and Ty, maybe, I think you met Leticia, but Leticia was born in Puebla, and I was a Spanish language instructor for a number of years. And I said, Leti, I want to come up with this mnemonic device to capture psychosis. Something like see cosas is psychosis. See things is psychosis. Doesn't that sound great? She says, that sucks. That's my supportive wife. So she took her Velasquez bilingual dictionary, she took LaRue's thesaurus, and she went to the bedroom, and I told her all the symptoms and all the different ways you could say psychosis. And she came up with clave. Clave. Use the clave to detect la enfermedad mental grave. Clave means clue or guide or key. Use the clue or guide to detect creencias falsas, delusions, lenguaje desorganizado, disorganized speech, alucinaciones. What kind of alucinaciones? Ver cosas que no existen o escuchar sonidos o ruidos o voces que no existen. Usen la clave. So we're not talking about thought disorder or cognitive impairment or psychosis or schizophrenia. We're teaching people to use la clave. And that's informed our brochures. That's informed our website. We've come up with a toolkit where we started out first, where I presented La Clave live. Alex Capelowitz got some funding through AstraZeneca, and we put the live presentation, as we call it, a class now, La Clase, where I talk. And these use video clips. So we use music, Maná, El Muelle de San Blas, to illustrate delusions. We use Cantinflas, his inimitable way of going from one idea to the next for comedic purposes to illustrate a disorganized speech. and Alucinaciones. Some of you might be familiar with the group Son by Four. Sofia is a wonderful song. I've spent a lot of time listening to music to capture psychosis and use it in terms of educating the community. So the other thing is I was running a summer program in Mexico for 15 years, a research training program. And we would work with promotoras, healthcare providers, community lay. And we showed up to show our DVD and our laptop and our cañón, or the projector, LCD projector. And we go into this home of one of the promotoras, and they didn't have electrical outlet in their house, in their family room. And so we came up with a flip chart that doesn't require any electricity, La Clave Sin Luz. And most recently, with our funding from NIMH, we developed a 15-minute film. And this is what we're using a lot to educate people. It's a narrative film. Instead of a talking head, we're instead having emotion-based kind of film to get people to begin the discussion. And you can watch La Clase and La Película going to our website, uselaclave.com or uselaclave.com. Point about all this is we've evaluated each of these toolkits, and we know that they increase, let's see, each of the toolkits are informed by the conceptual model. We've tested them for efficacy and in some cases effectiveness in Mexico as well as in Southern California. For example, one of my favorite studies that we've done, still hasn't published, Andrés Nicasio is the first author. We showed we used SurveyMonkey, over 200 health science students in Puebla, Mexico, and they're randomly assigned to a TED Talk, a movie, the movie, La Clave, la movie, La Película, and the class. And we then, at the end of having watched that, the TED Talk on social ecology or a movie or a class, we showed a similar vignette, not Olga, but Elsa. And you can see that most of the people in the TED Talk made attributions to the social world about the divorce or the difficulty, but less so in the movie and the class. And then reference to any psychotic symptoms, the possibility of delusions, the possibility of hallucination, the possibility of disorganized speech, 20% in the TED Talk, but 70–80%. So this gives you an idea of how we went about to test that. All right, so we've got the conceptual model, we've got our messages, we've got our toolkit, and now we're ready to go. And we were funded through NIMH to launch this campaign. We chose a highly dense Latino community in the San Fernando Valley. You can see that on average, there's 77% identified as Latino in these zip code areas, San Fernando having the largest group. And we chose this community because this is San Fernando. Here around the blue line are the zip codes that we use. We chose it because Dr. Alex Kapelowitz, my friend and colleague, Alex, Mary and Ty know Alex well, is the chief of psychiatry at all of you here, a major county hospital. And he's also the medical director at the outpatient clinic here. And so we were able to then recruit Alex, being in charge. Anybody who suggested that they might have a first episode of psychosis, we would then send our clinical research team and do an evaluation to see if they met criteria for first episode psychosis and do the evaluation. So we were able to assess first episode psychosis over a 4-year period, more than a 4-year period. Okay. So here, let me share with you a little bit of the design. So for 16 months, we did a baseline in terms of the duration of untreated psychosis. 24 months, 2 years, we carried out the campaign. And then 16 months, we did a post-campaign assessment of the duration of untreated psychosis. Our main hypothesis was that, one, we would expect, given the data with regard to use of mental health services of Margarita Alegría, we would expect that if they're foreign-born, that they would have a higher, a longer duration of untreated psychosis, regardless of the time period. So that's one thing. And the second thing, we would hope that with the campaign, we'd see a reduction in the duration of untreated psychosis, and we would also see it lasting past the campaign period. So let me share with you a little bit about the campaign before I talk about the data. Tied to Lloyd Rogler's and Dharma Cortez's Pathways to Care, we wanted to focus on the general public so that we get the word out to the families. We went to churches, health and mental health clinics. We went to beauty salons, went to schools, general public, and at the schools we talked to family members, PTAs. We also reached out to the professionals. We did workshops for healthcare providers. We did workshops with police, or meeting with police. And then we did networking with professionals. So here's some pictures to make it really concrete. The swap meets were really important to us. Swap meets are, I don't know if you have them in New England, but it's a place where people with limited resources can get products at a very limited cost. And so we would hang out at swap meets. Healthcare, health fairs, Rosalba and Eba, our two outreach folks. I was blessed to have them working with us, so dedicated, have a great heart, and really reached out to the community in different ways. We spent time at, here we went to a CCD, Catholic, some of you are Catholic, have to spend your Saturday morning sometimes learning about different things. Fortunately, they allowed us to come and talk about psychosis and mental health issues, and we showed our film, La Película. We spent time with churches and ministries. Big Christian churches are big among the Latinx community in Southern California. We spent time with them and reaching out to the professionals. The police, Rosalba and I would go to roll calls. One day we went to 7 roll calls starting at 5 in the morning every hour or so. We were just hung out there. They're very appreciative of coming out there. I met with the number 2 person in command of the LA Police Department, obviously, and he says, this is a win-win for us. You help us, and essentially he's saying, you help us prevent having altercations with people with serious mental illness. And so we met with them. We were in the newspapers. This is a Spanish language newspaper that's widely read. We're on TV and the radio. We went in billboards throughout the community. That's just for a month period at the peak. This is an example of our billboard. Bus benches as well, because this is part of our community. So we really did what we could. And then this is our website, uselaclave.com. Used a number of different ways to reach out to the community. So here's a little bit of the data. One of the things that strikes me about campaigns is a little assessment of the process. People carry out the campaign, but did it reach folks? And what were the units? And so here's an example that we kept a tally of all the contacts that Rosalba and Eba made, and this is for a 1-year period. We contacted at least 13,000 people, and you get the idea. We contacted a lot of people, and we received very positive feedback and evaluations of the message. In fact, we have a paper right now under review in early intervention about Rosalba and Eba's workshops. Now, was the message received? We came up with a 1-800 number. One of the challenges for us is it would refer people to the number at the outpatient clinic, and we weren't really sure that they were being seen or what. So we came up with this idea of a 1-800 number. We had hired a public relations firm, and they had suggested this. So this 1-800 number was a number we used in our campaign. And the individual would call the 1-800 number, go directly to the outpatient clinic. And so we could track the phone numbers that called. And so we could assess when we were on TV, this has really got the biggest bump. And there's 3 different distributions here. One is the phone number that had the 818, which is for San Fernando Valley, phone number outside the 818, but still in California, and then the phone number outside the state. So our biggest blip was when we were on TV, and we're really interested in this blue line in the San Fernando Valley. So on that given week, when we're on TV, we had 12 calls on the 1-800 number. When we're on the bus benches and the junior posters, we would have over these 3-week period, 7, 8, or 9 phone calls and others. So we think there's some evidence that the message was received. Also, we would ask people while we carried out our assessments of the duration of untreated psychosis, have you heard of La Clave? Well, in the baseline, nobody heard of La Clave. During the campaign, 9 of 55, I wish all 55 had heard about La Clave, but that wasn't the case. And then the post-campaign, these data we need to update, but only 2 recognized La Clave or heard of La Clave. And those 2 were like a month after the campaign ended, or 2 months. So that's some evidence that the message got out. Here's some, gives you a peek in terms of who the folks were that we identified. Largely male, largely US born, about 24, 25 years of age, almost 12 years of education. And they were rated themselves as being able to speak English and Spanish about equally well. So this gives you a little bit of background to our folks. Now, what I want to do is just tell you one of the reasons why it's difficult, I think, to reduce the duration of untreated psychosis, because the standard deviation is really great. And so it's hard to pick up an effect. And here, this is the duration of untreated psychosis for the onset to first antipsychotic medication. You see that 44%, less than 50%, had less than 6 months. And so most, the rest, of course, had more than 6 months. And you had even individuals 10, 12, 10 to 13 years since their onset and not receiving any care. The other duration of untreated psychosis, the first antipsychotic medication, we wanted to assess just health help seeking. And you can see that the duration of untreated psychosis, if you use as the offset help seeking, it's a little bit less. One thing is that the Rays had a median duration of untreated psychosis of 74, and our median's 39, which really surprised me. But anyways, that's what it is. So just want to remind you what the hypotheses were in the design of this particular study. And I'm going to give you just a little bit of the data. So let me just say, first off, we did not see any effect of the campaign or any, the way we construe this is we move the needle. Was there an effect of the campaign? No, there wasn't an effect of the campaign, but I think we moved the needle and we can improve things in the future. But here's data. So with duration of untreated psychosis to antipsychotic medication, no evidence to support that there's it's a function of the time period of the campaign or interaction. But this is to the duration of untreated psychosis to any healthcare. Any healthcare. So this suggests that our campaign may have played a role in helping people get to any healthcare. Didn't help them get into receiving antipsychotic medication. And so you see that you get a main effect for the time period, you get a main effect for whether they're born in the United States, and also you get an interaction. So if you look at any time period, if you want to tease this apart, there's really, if you compare any of these time periods, there's no significant difference when you just assess that. So to me, this suggests that maybe it plays a role, but it's not as strong as we would like it to be. And this is getting into any healthcare. Again, it's not about duration of untreated psychosis to use of antipsychotic medication. So we think this suggests that we're starting to move the needle. What really stands out is the US versus foreign-born. So the number of weeks for the foreign-born, this is with just getting into any healthcare, we're talking about almost 3 years. With antipsychotic medication, we're talking more than 4 years. And so to me, this is a really important finding. For the foreign-born folks, the duration of untreated psychosis is really much greater than the US-born. All right, and let's see if we have some time, 5 minutes. Let me just share with this. Alex really likes this figure. I'm ambivalent about showing, I'd like your opinion on this. None of this is statistically significant. But when we, quote, recruit people into the study, we recruit people from the target community, but we also recruited people from outside the target community, outside those 6 zip codes, right? So Rosalba and Eva, it's really clear. That's where we want to put our efforts, are in those zip codes. If they were asked to do something outside the zip codes, that we didn't do it. Only the efforts within the zip codes. Now, clearly, people who live in those zip codes have family that live outside the zip code. So you can't really necessarily, it's not a hermetic seal. But what I wanted to look at is how about those folks outside the target community versus those inside the target community. And none of this is significant, but it's just really interesting that there's almost identical duration of untreated psychosis outside the target community, but you get the pattern that you would expect, that during the campaign within the target community, you see a reduction. And then it goes back up to something that we didn't expect. So Alex says this is one of those so the stats don't support us, but the I may take place. So right now with the World Series, you have the analytics and you have the managers who look at the ball player and use their eyes. Alex is looking at the eye, using the eyes here, not looking at the analytics. Anyways, so the summary of the main findings are that the message was delivered and received. The campaign may have contributed to a reduction in any treatment seeking, but not in time to first antipsychotic medication. And the immigrants have a significantly longer DUP. So we're making the argument that we move the needle, but we've got more to go. But I want to leave you with just a little bit of qualitative data. There's this one case that just really struck us, and we had a number of cases, really sad cases, as you can imagine. But this really tells me what one of the main take-home messages that I like to share with you. So Rosalba met this man after giving him a brochure at the swap meet, and the man said to him, his father said to her, "This is my son, he's got these things." And she says, "Contact the 1-800 number." And then this man would text Rosalba several times and say, "My son's doing this or doing that." And she says, "Contact the 1-800 number." So he had the information, right? So the idea is he's making the illness attribution, he's going to seek help. But no, he contacts Rosalba. Finally, the son gets aggressive and he calls the police. The police show up and he says, "Take my son to a drug rehabilitation." He had this idea that he suffered from the use of drugs. Police said, "We can't take him to a drug rehabilitation unit. We can take him to jail, or we can take him to a psychiatric hospital," which of course is all of you. He said, "No, he's got a drug problem. Take him to drug rehabilitation." Police said, "We can't do that." And then the police, who had participated in one of our meetings, said, "At the psychiatric hospital, they have a program called La Clave." Oh, the father says, "I know about La Clave." Okay, take him to the psychiatric hospital. So who knows how things would have turned out. But Do Mayer, a wonderful colleague of ours in the School of Cinematic Arts, she really orchestrated the película. If you have a chance to see it, I think it's just a wonderful, she and I were the executive producers. She says she's not into information campaigns. So when I wrote this grant, I talked about information campaigns, and that's what people talk about, information campaigns. It's not about information. It's about starting a conversation. It's about creating a dialogue. And this represents the value of creating a dialogue, that the police knew about it, and this gentleman knew about it, and it's a conversation. And so this is an important point. I used to think, just get as many people in to watch the La Clase, or get as many people in to watch the movie and they'll get it. Nope. There's a lot of stigma. There's a lot of problems with this. So you need to have a conversation. So future directions. Prepare. We hired Rosalba and Eva 2 or 3 months before we started the campaign. Mistake. We should have hired them a year before we started the campaign so that they make connections with the community. They knew some of the community. But yeah, so that right when we start the campaign, they're ready to rock and roll. But instead, they took 6 months to identify who the key players are, and we didn't give the community a full dosage. The other thing is, I think 2 years is too little. We need 3-year campaigns. And the last thing is we need to embed it with a coordinated specialty care. Too often, for example, we'd meet with the families and they said, that clinic, they don't accept kids, or that clinic, they don't accept, you need insurance. So it had these misconceptions. But if we had worked with a coordinated specialty care, they could help us reach out and show that they are well-meaning and that they could meet their needs. So here's the conclusion: is we develop interventions for early psychosis, which I think is really important. I'm really excited, and I think it's the way to go. Let's not overlook low and middle income countries. Let's not overlook communities of color. Providing coordinated specialty services is great, but alone for low and middle income countries and for communities of color may not be enough. We need evidence-based campaigns that are conceptually informed, as well as evidence-based interventions, treatments. So we're hopeful that both coordinated specialty services in conjunction with strong campaigns will reduce the duration of untreated psychosis in underserved communities. So as they say in Spanish, colorín colorado, este cuento se ha acabado. In other words, that's the end of the story. I want to point out, though, that our main funding is the National Institute of Mental Health, main supporter of this campaign. National Institute of Minority Health Disparities helped support our summer research training program, where we carried out a number of these evaluative studies, California Community Foundation. And we had a number of wonderful colleagues, Carmen Lara in Mexico, Jody Ullman, Concepcion Barrio, Bill Vega, Do Mayer. And I don't know why Alex Capello is in here. It's because we gave a similar presentation at Grand Rounds. And so, but Alex Capello, it was clearly, we couldn't have done this without him. And here's my contact information, uselaclave.com. Muchas gracias.
Thank you so much, Dr. Lopez. That was such a fascinating talk, and yeah, such important work. And it's really cool to see this, like the really concrete results of this massive informational campaign. Yeah, and it's really fascinating to hear you talk about it. So yeah, so we can open up to some questions now. Feel free to use the raise hand feature if it's accessible. If you can't find it, you can unmute and I'll try to keep track of people's questions.
Okay, I'm going to stop sharing and put you all on a gallery. Okay.
Yeah, Michelle.
Yeah, thanks, Dr. Lopez. This was super, super fascinating and really, really important work. I'm going to lower my hand here. So I just was curious about, so the construct of duration of untreated psychosis, the reason, as you outlined, that we would want to intervene is so that we can affect long-term outcomes as well, given the association between longer DUP and worse outcomes. So I'm wondering what effect a campaign like this might have on future engagement with the mental health services that you described, not only initiating an earlier first point of contact, but then what happens after that first point of contact for in general, but then also in the specific communities that you're describing in your research.
Yeah, let's see. One of the things that happened is when we go give our talks, people don't, I don't know if this is what the focus of your question, Michelle, and if it's not, please let me know. We heard about everything. We didn't just hear about psychosis. We heard about spousal abuse. We heard about child kinds of issues. We heard about all kinds of things. And that was really challenging. I'll never forget, we go to this church and we give this talk, and there's 3 or 4 ladies, and this one lady's just going on and on about her son or her daughter or whatever, and these other 3 ladies are patiently waiting. There's such a need for mental health kinds of issues, and so you have to be well prepared, and you have to have a list of resources so that you can share them with them. But at the end, when you leave after giving the talk, you just feel frustrated that there's just so much need and it's not being addressed. And so I hope in a small way we're able to guide folks in the right direction. But we don't know if they contacted the person for spousal concerns or for mental health issues for their child, etc. Of course, we were interested in psychosis and serious mental illness, but we got everything. I'm not sure if that answered your question.
Yeah, thank you. It did in a way, and also kind of address something that is interesting as well, just the wide range of needs for mental health services. Yeah, I guess I was also kind of curious, and I guess maybe you don't have the data on this yet, but I study psychosis, so I'm interested in that population specifically, kind of after
Right.
the first point of treatment, whether individuals, keep taking medication as a result of having increased health literacy or continue to attend treatment, or whether there's a higher dropout rate. Or so I was curious about that as well, but it sounds like maybe, I
Right.
don't know if you have data on that yet.
Sure. So we have two papers. One is just how to recruit folks for these particularly communities of color, and particularly Latinx communities. Um, you can imagine what the experience is for people with first episode psychosis. It's very chaotic. And then let's say the police are involved, or let's say you're hospitalized. And let's say you're from a community that doesn't trust the police. And then a community that doesn't trust the healthcare provider. And then you're thrusted into this hospital, and they send you, because they're in the local community, they don't have any beds. So they send you 30, 40 miles away to another institution. And then the parents aren't informed of this because they're an adult. And so the parents are trying to locate them. So this is not a kind of an experience that people then want to talk about, that people want to experience again, and that people, this is a really difficult time. And so we think that one of the reasons why people keep relapsing is because it's such a horrendous experience and they want to disassociate themselves. So we have a qualitative paper on pathways to care. We submitted, it wasn't accepted, and we need to do some more work on that. But in this Pathways to Care, we point out some of these issues. Also, we have a paper on family issues and duration of untreated psychosis, a qualitative paper in early intervention. Mercedes Hernandez, who's now at UT Austin social work, was a leader in that. And she also has a first author in a paper on recruiting folks and addressing some of these issues and developing the trust. We were very fortunate. Alex Kapelowitz has been working with Richard Franco for a number of years, and he is so talented in recruiting people. And this is a difficult issue. People don't want to talk about it, particularly persons with the illness. And he has a way of getting into people's to get them involved. And you want to give them a service. So those are some places that you can go to. Great question though. But we need to study more the pathways to care. That is so important.
Any other questions for Dr. Lopez? I have one that I could throw out there. I think it's so fascinating that like one of the main results of this campaign was this increased outreach to, like, people were seeking out treatment, but it wasn't always the treatment that you expected, like the mental health specific treatment, but more this like maybe the medical system more than mental health facilities. And I was wondering what your thoughts are on that, and if you think that like, would it be a valid target to try to increase the like connection between mental health and medical facilities? So like if people show up to a medical facility with a mental health issue, there's like a practitioner there, a mental health practitioner there that could help. Or do you think it's more about like not knowing where to go with those issues? Yeah, I just want to hear some more of your thoughts on like what increased outreach to treatment, but not necessarily mental health treatment.
So if you go back to the TIP study in Norway, it was a multifaceted campaign. Keep referring to Max Birchwood. They had the thought, social medicine, right? Primary care provider, right? Just train the physicians, and then they'll refer to the specialty mental health care. Easy, right? So they did that. This is that Helen Lester paper. Guess what? A year later, any reduction in duration of untreated psychosis? Nope. You scratch your head. Oh my God, healthcare providers, they're the ones who are referring to mental health specialty care. Why is that? Because there are other factors, there are other barriers. Family, schools, criminal justice, all the other areas are not contributing to facilitating them getting to care. So definitely healthcare providers are needed, but healthcare providers by themselves, even in the social medicine kind of healthcare system, is not sufficient. It's just one element, and it certainly should be included. And we reached out to them as well. But that is an important part, but you need multiple folks, multiple facets.
That makes sense. Thank you. And I'm seeing a
You're
question
welcome.
from Ka.
Yeah, this is really fascinating talk, and thank you so much. And I'm wondering, so the differences between the foreign-born versus US-born finding is really fascinating in the fact that how much do you think is maybe attributed to, their legal status, that they are like, some of them are undocumented, that they might not want to even knowing the information and then calling because they are like scared about it, like legal status, as well as how much is about maybe translation or language issue, or this kind of like no health insurance, that kind of barrier that they are less likely to just even reach out to any health professional. And do you have data to moderate that?
Yeah, that's a great question, Ka. So at this point, I don't think we have any papers on that, or we're doing any analysis in terms of the specifics, or at least that they don't come to mind. We are writing a paper on the duration of untreated psychosis of the overall sample. But here's one of my close colleagues in Mexico is Nelly Salgado Snyder. She did work on depression and Latinx women, on both sides of the border. And one of the points she makes is that when you cross the border, you don't leave your cultural baggage behind. You bring your cultural baggage with you. And so in Mexico, they have a very different system of care. They have Seguro Social, they have different insurance, and they're not knowledgeable of the system of care here. And so that's new to them. That's one factor. The other is the immigration status. We asked people, we tried to get at this. Those of you who study immigration, Nelly suggests this is how you ask the question. You don't ask them, are you an undocumented immigrant? That probably wouldn't work. That was a dumb joke, I'm sorry. But what you ask is, how difficult was it when you crossed the border? And they say, oh, not a problem. And those who had, oh gosh, I spent time here and there, they may have that. So it's a proxy to that. We asked people if it would be okay if they had a social security number. So we have some data on whether or not they have a social security number. So we might be able to get into that. But one issue that comes up to me is the whole notion of stigma. When that time that I went to the church, this one lady said, we show them, we say this about mental health, and has anybody had a mental health issue in their family? And this one lady says, I've had a mental health issue in the family, but I'm not going to talk about it. Okay, that's fine. We show the movie, and then other people start reflecting a little bit on mental health issues, and then she discloses something about her family and some of the issues. So it's not something we typically talk about. And in fact, the worst case that reflects this stigma is that one of our participants, family participants, told us this story where the police came and the ambulance came and took their son to the psychiatric hospital, all of you. The next day, they found spray cans of paint on their garage door. Aquí en esta casa viven, es una familia de locos. In this house is a family of crazy people. Somebody spray painted on the garage of this family about that. So there's a lot of stigma associated with this. Those are two factors. Another thing is a colleague of mine, Carmen Lara, there's a sense of resilience and the sense of you just bear with it. She says in Mexico, the people don't refer their loved ones for mental health concerns until they're standing on top of the kitchen table urinating. Sorry for that kind of gross image. But in other words, families put up with a great deal, And and so they don't recognize the illness. They don't recognize it as an illness. So anyways, those are some thoughts. No data to support that, but there are a lot of factors that contribute to this difference in the duration of untreated psychosis for the immigrants. Another factor might be trauma. And listening to the interviews, trauma comes up quite a bit. You can imagine in crossing borders, being undocumented, family kinds of trauma. We read Van Osse's paper on genetics and environment and childhood adversity, and so we included in our qualitative interview to try to address some of the issues of trauma. We also included discrimination, but so trauma, it's a very private kind of thing, and it's I think people just, Alex calls it, this is back in the day when we were kids, this is before many of you are probably born, you students, cancer. I'll never forget my grandmother had died of cancer. She was 62 years old or so. And they wouldn't even say the word cancer. They would say she had, she wasn't doing well, or she's got this, they lower their voice if they say cancer. She says, Alex says, this is the cancer of today is schizophrenia, psychosis, particularly among our community. So those are some thoughts.
Thank you so much.
Any other questions? All right.
Okay,
Awesome.
I think we're done then. Well,
yeah, well, so thank you.
All right.
Thank you again for coming, Dr. Lopez, and thank you everyone for being here. And yeah, please join me in thanking Dr. Lopez one more time altogether. So thank you for being here.
Well, thank you guys for inviting me. All right.
Steve, it's great to see you. Thanks so much.
Thank you, Steve.
Wonderful
Hey,
work.
take care, Ty.
Wonderful work. Thanks for what you're doing.
Thank you. All right. Take care, everybody.
Bye.
Bye-bye.
Bye-bye.